To this webinar. Thank you everybody for attending to this webinar. My name is Carolina Fernandez and I am from Spain. And today I'm going to introduce you to Marta Skudra, who is a physiotherapist specializing in urology and gynecology within the field of oncology. She has a degree in physiotherapy and a master's degree in rehabilitation from Riga State University. And she also has some research on rehabilitation options for patients following prostate cancer surgery, with a particular focus on the role of physiotherapy in reducing urinary incontinence, restoring sexual function, and enhancing overall quality of life. And she currently works at our Riga East University Hospital, Labian Oncology Center, where she collaborates closely with specialists in urology, gynecology, and rehabilitation. Marta also is a lecturer at Riga State University, and these sessions will explore the role of physiotherapy following radical prostatectomy, with a particular focus on managing urinary incontinence and supporting the recovery of sexual function. And the presentation will also have a brief cover in medical aids available for incontinence and provide an overview of the surgical procedures and outline a progressive exercise plan designed to aid rehabilitation. So thank you, Marta. It's your turn.
Thank you for introduction. And now okay. So everything is fine. Presentation you can
Perfect.
see. Yes, okay. Then now I start. Good afternoon. My name is Marta Skudra. I'm a physiotherapist working at Latvia Oncology Center. My interest in prostate cancer rehabilitation began during my master's studies, where I focused my thesis on prostate cancer. Later, I had the opportunity to work in both the gynecology and urology departments, and urology department often met patients with prostate cancer. The experience made the topic especially important to me, as I frequently work with patients in acute phase right after surgery. Nowadays, thanks to close collaboration with urologists, I also meet patients before surgery during the rehabilitation phase. At this stage, we discuss possible side effects such as urinary incontinence and sexual dysfunction. Patients are encouraged to start practicing pelvic floor muscle training before surgery. This is very useful because learning how to feel and control these muscles before the nerves are affected helps patients return to daily life faster and more effectively after surgery. This was just a short introduction, and now I'm really glad that we are here today to continue with our main topic, prostate surgery and rehabilitation. Let us start with the basics. What exactly is prostate? The prostate is a small gland that is a part of male reproductive system. It's located just below the bladder and it's front of the rectum, and it surrounds the urethra, the tube that carries urine out of the body. The main function of the prostate is to produce fluid that nourishes and protects sperm. This fluid mixes with sperm cells to form semen. Also, the prostate is a relatively small organ, about the size of walnut. It plays a central role in male fertility and urinary functions. Prostate cancer is often silent in its early stage. Most men do not notice any symptoms. As this disease progresses, however, patients may start to experience certain complaints. The most common are urinary problems, such as frequent need to urinate, especially at night. Some men may notice blood in the urine or semen, or difficulties with erectile functions. In more advanced cases, pain can appear in the back, hips, or chest. They may also be numbness in the legs or feet, and even problems with bladder or bowel control. A few weeks ago, I had the chance to take a part in radical prostatectomy together with the surgeon. When they take prostate was removed, and I surprised that to see how much really look like a walnut. Inside the tumor appeared small hard nodules, almost like little seeds. From a physiotherapist point of view, they even remind me the trigger points, tiny tense spots within the tissue. While watching the procedure, I could follow how the prostate was separated and removed, and afterwards the doctor even let me touch this prostate, and I could clearly feel the solid formations inside the prostate with my own hands. And during the surgery, at the moment when the prostate was detected, I observed a sudden downward shift. It reminded me of trampoline. When the fabric tears, everything sinks and falls through. Of course, the bladder does not fall out, but this visually helps us to understand how after prostate and its ligaments are removed, the bladder descends slightly. This descents increase pressure on the pelvic floor muscles, meaning they must be stronger to provide support. It also made me reflect on the use of sling in men after prostate surgery. This device can help elevate the bladder if urinary incontinence persists. In many European countries, this practice already well established, while not yet common in our setting. I believe it will available also in Latvia as an important option for patients who don't regain continence naturally. In men, prostate cancer is one of the most common types of cancer, and after the cardiovascular disease, it is also leading cause of death worldwide. If we look specifically at Latvia, data from 2017 shows that prostate cancer was the most frequent diagnosed malignancy among men. Another important point is the trend we are currently seeing. Prostate cancer is no longer only a disease of older men. More and more cases are being diagnosed in younger men as well. This makes the topic especially relevant when we think about prevention, early diagnosis, and rehabilitation. Around 60% of prostate cancer cases are diagnosed in men aged 65 or older, with the average age diagnosed being 66. The disease is very rarely detected in men under the age of 40. However, recent trends show that prostate cancer is becoming more common in younger men, which is a concerning development. One of the biggest challenges is that the disease is often detected at the late stage. This is partly because men are usually less proactive about their health and less likely to attend regular checkups. At the typical age of diagnosis, many patients already have multiple comorbidities. This additionally, health problems can complicate treatment decisions and also have strong impact to the rehabilitation process. Thanks to early detection and timely screening, in about 81% of cases, prostate cancers are still confined to the prostate gland at the time of diagnosis. Only around 4% of cases are found to have spread extensively. Even so, most patients already experience symptoms when they are diagnosed. These are most often related to the urinary dysfunction, such as incontinence and sexual dysfunction, with erectile dysfunction being the most common. This combination of physical challenges highlights just how important both early detection and early rehabilitation are for patients. In Latvia, patients with prostate cancer are monitored, treated, and followed by urologists or medical oncologists. If no recurrence is observed within 5 years after radical therapy, dynamic follow-ups may be delegated to general practitioners, with the option of referring patients to specialized institutions if it's necessary. Surgical treatment is performed by urologists and specialized in medical institutions. The surgical strategy and approach are determined by the urologists based on the decision of a multidisciplinary tumor board, which includes urologists, radiation oncologists, and medical oncologists. In cases where surgical treatment does not achieve the desired outcome or it's not feasible, further management, whether hormonal therapy, radiotherapy, chemotherapy, or a combination of modalities, is decided within a multidisciplinary tumor board. When it comes to manage prostate cancer, 2 approaches are often discussed: active surveillance and watchful waiting. Active surveillance means closely monitoring the cancer with regular checkups, PSA tests, and sometimes biopsies. The goal is to delay or avoid treatment until it becomes truly necessary, while keeping the disease under careful control. Watchful waiting, on the other hand, is a less intensive approach. Instead of frequent testing, the focus is on treating symptoms if and when they appear. This strategy is usually chosen for older patients or those with serious comorbidities, where aggressive treatment may not improve quality of life. So while both involves observation, active surveillance is proactive and structured, where watchful waiting is more about comfort and symptoms management. And I want to say that the physiotherapists have a big role also in these phases. The physiotherapist supports the patient physical and psychological health, aiming to improve quality of life and reduce overall health risk, while oncological treatment is not immediately required. Promotion of physical activity, encourage regular exercises tailored to the patient abilities, normalization of body weight, supporting weight management strategies to lower health risks, improvement of cardiovascular health, enhancing endurance and circulation through safe training, enhancement for psychological well-being, reducing stress, anxiety, and depression through physical activity and counseling support. Preventive pelvic floor muscle training, strengthening muscles to reduce urinary dysfunction after potential future treatment. Promotion of healthy lifestyle, education about balanced nutrition, sleep, and stress management. It's also very important to support this patient in this phase also. And now I would like to share a clinical case. The patient underwent surgery in January, and I first met him in March. In the following slides, I will present this case in more detail. Preoperative epicresis. Due to the elevated PSA level, the patient underwent diagnostic investigation, which confirmed prostate cancer in a localized stage. No distant metastases were detected. Radical treatment was indicated at the patient consent to surgical management. The patient was informed about the expected outcomes to treatment process and the post-operative period. Planned surgery was radical prostatectomy with bilateral regional lymphadenectomy, and procedure is scheduled for early January, like I say. On this slide, we can see the main steps of radical prostatectomy that are particularly important for us physiotherapists. First, we notice the surgical incision. This immediately reminds us that the scar will be present and we will need to assess and address it during rehabilitation. Next part of the rectus abdominis fasciis muscles is dissected. This makes us think about the potential impact on the abdominal wall and how this may affect overall core stability and function. A very important step is removal of the prostate itself. During this procedure, ligaments are detached, and as a result, the bladder will be positioned lower than before, like trampoline. Finally, in the image, we see the prostate being separated from the urethra. This has several implications. Nerves and muscles are affected, and the functional length of the urethra is reduced. All of these surgical aspects directly influence the challenge we need to consider in the physiotherapy process. And now about internal. Urethral sphincter is a smooth muscle structure located at the bladder neck. Its primary function is to provide involuntary control of urine incontinence by maintaining closure of the bladder outlet at rest. During radical prostatectomy, the bladder, neck, and surrounding tissues are surgically dissected, which may partially or completely compromise the internal sphincter. Damage to this structure reduces the passive involuntary mechanism of continence, placing a greater demand on the external urethral sphincter and pelvic floor muscles. As a result, patients may experience post-operative urinary incontinence, particularly in the early recovery phase. Rehabilitation strategies, including pelvic floor muscle trainings, aims to strengthen the external sphincter and compensatory mechanisms to restore continence. And during radical prostatectomy, the anatomical proximity of the prostate to the urethral sphincter makes it highly susceptible to surgical impact. The external urethral sphincter located just below the prostate apex and may be partly damaged or weakened during dissection and removal of the prostate. Even with nerve and sphincter sparing techniques, structural or functional compromise of the sphincter can occur. Such involvement contributes to post-operative urinary incontinence as the sphincter ability to maintain closure against intra-abdominal pressure is reduced. Physiotherapy and pelvic floor muscles training play a crucial role in rehabilitation by compensating for the weakened sphincter functions and supporting continence recovery. After prostate surgery, the external urethral sphincter becomes the primary structure responsible for urinary continence. Since the internal sphincter at the bladder neck may be weakened or removed during surgery, continence control depends mainly on the voluntary contractions and strength of the external sphincter. Strengthening the pelvic floor muscles is therefore essential to support the external sphincter and improve continence recovery. And now we go back to my case. And in the beginning, I want to say that physiotherapy is becoming increasingly recognized and evaluated after radical prostate surgery. More and more physicians also acknowledge its importance in the rehabilitation process. For me, this journey started when I began meeting patients in the acute phase after surgery. I developed my own practice. I carefully note the date of each patient's surgery and marked in my calendar when I should follow up. Usually this was around 3 months later because according to the literature, by the time improvement in conditions should be already be expected and total incontinence should no longer persist. I also created a structured conversation guide for me, a kind of algorithm. If the patients reported that everything was fine, the call was short and simple. However, if patients still had complaints about incontinence, depending on the severity of symptoms and the patient's readiness to engage, I either provide education material suggested to consultation or both. This approach proved very effective. Many patients in Italy believed that urinary incontinence or sexual dysfunction after surgery was simply normal and something they had to expect, but with education and support, they realized that the rehabilitation can significantly improve their quality of life, because some patients think that this is normal if you have incontinence, if you have erection function problems, and this can understand to him better. These follow-up calls did not take much time, yet they played a crucial role in guiding patients into the rehabilitation process. Today, I see that both patients and doctors are becoming more and more involved in this pathway. And when the patients arrive for consultation for me, now I'm back to my clinical case, he reports stress urinary incontinence during physical exertions, as well as loss of erectile function. At night, he wakes up 3 times to urinate. In his daily life, the patient is physically inactive. His body mass index is elevated, and he presents with abdominal obesity. On examination, the post-operative scar is firm and rigid. An ultrasound assessment of pelvic floor shows reduced muscle strength. It was 3 or 5 on the grading scale. And there was a scar tissue of my patient, and because of limited physical activities and proactive behavior around the scar area, the patient has developed scar tissue thickening and rigidity. The lack of mobility and avoidance of local stimulation likely contribute to the formation of adhesion and reduced tissue elasticity. And to address scar tissue problems, several physiotherapy methods can be applied. First, soft tissue mobilization techniques, including gentle massage and mobilization, helps improve tissue elasticity and circulation. Second, silicone patches or gels can be used. They are effective in reducing thickening, decreasing itching, and regulating collagen synthesis. And third, shockwave therapy can be considered, or ultrasound therapy. This method helps to soften fibrotic tissues, improve microcirculation, and reduce pain. It is usually introduced after about 3 months post-surgery if we talk about shockwave therapy. And also my patient have weak abdominal muscles, and rectus abdominis diastasis after prostate surgery is not very common complication, but it may occur for several reasons. Like the surgery was performed throughout a larger abdominal incision. Like for me, it was open prostatectomy. The patient already had weak abdominal muscles or was overweight prior to surgery. And post-operatively, there was increased intra-abdominal pressures like chronic cough or constipations or heavy liftings. And also, if we can imagine and do good measures, we can use ultrasound to check it out. About intra-abdominal pressure refers to generated within the abdominal cavity by the coordinated activity of the abdominal wall muscles, diaphragm, and pelvic floor muscles. This pressure naturally fluctuates during daily movements. Under normal circumstances, the body compensates for increasing intra-abdominal pressure through the contraction of the pelvic floor and sphincter muscles, there be maintaining urinary continence. But like our case, the patient have problems in abdominal wall, in his pelvic floor muscles. This intra-abdominal pressure is not correct and problematic. Also, I use transabdominal ultrasound. And transabdominal ultrasound is non-invasive method used to evaluate pelvic floor function following prostate surgery. Also, with this measurement, it's enable assessment of bladder filling and emptying dynamics, but this do more urologists. We physiotherapists can pelvic floor muscle contractions and potential post-void residual urine. The examination provides objective data and muscle strength, coordination, and compensatory mechanisms supporting both clinical decision-making and physiotherapy planning. And how I say, in my cases, I saw that muscle strength was 3 out of 5. And in this image, in image A, we can see that pelvic floor muscles are in rest. This is like a horizontal line. And the image B, we see they have contractions as this is coming up. So if contraction is not possible or people don't it correct, this image don't change. It's like like A image everything. They do contraction, but we don't see this motion forward. And of course, very important for these patients are avoiding diaries. It is a simple yet viable tool for the assessment and management of urinary disorders. Patients are instructed to record the frequency and volume of urination, episodes of urgency, incontinence events, fluid intake, and nocturnal voids over several days. The diary provides objective data that helps clinicians evaluate bladder function, identify patterns of urinary incontinence, and monitor the effectiveness of treatment or rehabilitation. Introduction: avoiding diary after prostate surgery is particularly useful for assessing continence recovery and guiding individualized physiotherapy interventions. And provide objective information on urination frequency and patterns. It helps identify trigger of incontinence. It's maybe physical activity, maybe it's incorrect fluid intake, like in evenings or nights. Monitor nighttime voiding and possible habitual wakings. More of patients have like a habit to wake up and go to toilet, and after prostate cancer operation, it's also the habit. I wake up, I need to toilet, but sometimes it's not necessary. Track progress of continence recovery over time, supports patient awareness and self-management of bladder habits, guides physiotherapists in tailoring pelvic floor and lifestyle interventions, allows evaluation of treatment and rehabilitation effectiveness. Also, we can use the International Prostate Symptom Score. This questionnaire is an important tool for evaluating urinary symptoms in men with prostate condition. It allows us to measure the severity of symptoms such as frequency, urgency, weak, stream, or nocturia in a standardized way. Using this questionnaire is valuable because it not only helps us understand the patient baseline condition, but also allows us to monitor changes over the time and assess the effectiveness of treatment or rehabilitation. In this way, this questionnaire provides both patient and clinical with clear, measurable feedback about the progress of care. And when to start physiotherapy and how often? The start physiotherapy can be initiated already before surgery, like rehabilitation, I say, to teach breathing, circulation, promoting exercises, and correct pelvic floor muscle activation. After radical prostatectomy, pelvic floor training is usually started as soon as the urine catheter is removed. Commonly, it's 1 to 2 weeks post-operative period, provided, of course, there are not complications and the wound is healing well. And frequency. In the first 3 months, supervised physiotherapy can be 1 time per week for technique correction and progression and feedback giving to patient. And of course, it's daily home exercises for every day to go progress. Several short sessions per day. It's 3 to 5 times per day and to 10 to 15 contractions the patients make. And later phases like 3 to 12 months follow-up physiotherapy every 2 to 4 weeks to adjust the program and continue daily home trainings. And I want to note that consistency is more important than intensity. Regular daily training gives the best continence outcomes. The program may be adapted depending on comorbidities, physical activity level, and recovery speed. And also, it's very important to take look of importance of proper breathing. Diaphragm and pelvic floor work synergy, like I talked it before about intra-abdominal pressure. Correct breathing reduces unnecessary intra-abdominal pressure, prevents excessive load on the bladder and the urethral sphincter. Pelvic floor muscle awareness. Patients must first learn to identify and consciously activate pelvic floor muscles. Awareness ensures correct contraction, lifting and tightening, not pushing down, and prevents compensation by surrounding muscles, buttocks, thighs, and abdominals. And so also very important, and this part can be different for persons, because I have patients who in the first consultation understand, they feel how to contract, and I watching the ultrasound and I saw, yes, the contraction is good. Sometimes patients don't understand how to do this motion, how this work. They need maybe a week, maybe 2 weeks. And if we want to, they breathe correctly, it's also make time for more. And this is very very personalized period of time that we need to do. And also sometimes I think better than patients comes and they don't search Kegel exercises, because they come and they do like pelvic floor tilt exercises, they contract their buttocks or they contract their abdominal wall, and then we have big work to retrain this, because this pelvic floor is not about these muscles only. Automation of pelvic floor contraction. The goal is not only voluntary control, but also automatic activation. Training should include contractions during situation of increased intra-abdominal pressure, like coughing, sneezing, lifting, changing positions, physical exertions. Automation helps restore continence in daily life without conscious effort. Role in post-prostate surgery recovery, enhance urinary control, reduce incontinence episodes, supports faster returns, normal activities and quality of life. Combined with lifestyle changes and regular trainings, it maximizes rehabilitation. And also I want to say a common mistake that patients are doing, it's static training only. Sometimes I saw, yes, the muscle is working very good, I see it, but this muscles works good even the patient is lying or patient is standing. But if they start to walk or if they start to physical activities, this muscle don't work. They cannot do synergic. A frequent error is performing exercise only in static position. This does not effectively improve pelvic floor muscles function during movement. Importance of dynamic training. Training must be integrated with movement and daily activities. Contraction should be practiced during standing up, walking, lifting, coughing, sneezing, physical exertion. Dynamic training develops automatic activation of the pelvic floor under load, and it's very common mistake for patients. And also the patients, many patients visit the toilet prevently to avoid leakage. It is understandable because it's not very good for patient, but however, this strategy prevents the bladder from filling adequately, which over time may reduce its capacity and elasticity. When the bladder does not fill properly, it means the intravesical pressure is not generated. Normally, this pressure provides a stimulus for the pelvic floor muscles to respond and activate. Without this natural training from above, pelvic floor control may weaken. Early patients' education on the importance of the bladder filling and the restoring of psychological voiding habits is essential for maintaining continence and supporting pelvic floor rehabilitation. It's also, I think, one of things which we need to ask and tell our patients about this, how much time you go to toilet. Do you go to toilet when you feel this tension, or you go only because you think you can go this incontinence problem? And when expect improvement in urinary control after prostate surgery? In the first weeks, urinary incontinence is common immediately after surgery. The bladder and pelvic floor muscles need time to adapt the new position in the body. And many patients notice gradual improvement in urinary control within the first 3 months. How I say, I made these calls after 3 months because they need to be corrected. Regular pelvic floor muscles exercise significantly support recovery. And 6 months to 1 year, most patients experience substantial improvements within 6 months. For some, full continence may take up to 12 months. By this time, many can control urinary flow in daily situations. Stroke associational leakage may still occur during physical activities. On this slide, we can see several types of medical devices that may help in cases of urinary incontinence. This includes diapers and absorbent pads, which are the most commonly used. There are also condom types urine collectors, which can provide an alternative solution for some men. And finally, see also penile clamps, which are sometimes applied to temporarily control leakage. All of these devices can play a role in managing symptoms, but our goal in rehabilitation is always to reduce this need for them whenever possible. From my personal experience, I have noticed that many patients rely too much on pads or diapers for their own sense of safety and comfort. This, however, can make the body relax too much, as if it no longer needs to activate control continence. That is why I often encourage patients without severe incontinence, those with only mild stress leakage, to avoid using pads at home or in the other safe environments. This helps the body stay engaged, allowing to pelvic floor muscles to remain active and strengthen their control. It's also, I think, is a big thing where we need to think about and educate patients. And now about sexual rehabilitation after prostate surgery. Importance of early initiation. Sexual rehabilitation should be considered as a part of recovery if it's relevant to the patient. Early initiation helps preserve erectile tissue health, improve blood flow, and support the return of sexual function. And also medical collaboration, because in these functions, physiotherapists, one person don't make the big chance, big results. We need to cooperate with urologists or with pharmacological treatment. may be prescribed its PDE5 inhibitors to enhance penile blood circulation. Medication is often started shortly after catheter removal, like we start physiotherapy exercises for pelvic floor. Also, these medications are started depending on healing and absence of complications. And also, I want to say, colleagues, I encourage you to ask about sexual functions because patients are often embarrassed and sometimes even specialists are to this question. But we simply need to ask the question, for example, do you have any concerns about your sexual functions? The patients may answer yes or no, but they will have heard these words, this message. Often the first time they won't say much, but later when they feel safer with you, they may return to this topic and ask again. And this happens quite often. Once the patients feel safe in their environment, they start asking questions, they're able to bring this help early, it's relevant. Otherwise, sometimes a patient comes back after a year and says, actually, this issue is also important to me, but the time was lost and it's no longer be a could have been in if we start this rehabilitation earlier. It's also ask questions and patients if she feel important, they answers. If we think about sexual rehabilitation, this is also use of vacuum erection device recommended as a non-invasive method to promote penile blood flow and prevent tissue fibrosis. Frequency usually advised daily or at least 3 to 4 times per week for 5 to 10 minutes, even if sexual activity is not attempted. Can be used together with pharmacological therapy for better outcomes. And the physiotherapist role, it's like I say, encourage open discussion about sexual health as a part of overall rehabilitation, support patients and partner education, integration of pelvic floor training for sexual function, and reducing of performance anxiety. Goal of sexual rehabilitation is maintain erectile tissue oxygenation and elasticity, facilitates recovery of erectile function, and improve quality of life. Erectile function is usually absent immediately after surgery. Nerves and blood vessels that support erectile needs time to recover from surgical trauma. Early initiation of sexual rehabilitation is recommended to preserve tissue health. It's 3 to 6 months. Some men may begin to experience partial erection, especially with the aid of medications. Nerve healing is slow. Progress varies depending on age, preoperative function, and surgical treatment. Nerve sparing or non-nerve sparing, 6 to 12 months. Noticeable recovery may occur in patients who had a good erectile function before surgery and underwent nerve sparing procedures. Rehabilitation remains essential during this period. And 1 to 2 years, erectile functions recovery can take up to 24 months, it's 2 years. Some men regain succession spontaneous erection for intercourse, while others may require long-term use of medication or devices. If erectile function does not return, penile implants or prostheses may be considered. And if we think about how it's look and how it's like, penile prosthesis, surgical option when conservative treatment fail. Implantable prosthesis more advanced, allows control of rigidity and more natural appearance when they flaccid. Penile implants devices that mechanically restore erectile rigidity provide reliable erections suitable for sexual intercourse. High satisfaction rates among patients and partners. And recommended these prostheses and implants only when less invasive therapies are ineffective, required surgical procedure and preoperative counseling. Outcomes is restore sexual function, improves quality of life and intimacy. And also specialists say that it's 2-3 years after surgery when the patients can to start think about this if erectile function is not back. And like a summary, the urinary incontinence, like pelvic floor muscle training, it's awareness, strengthening, dynamic task, breathing, coordination, bladder training, Stress incontinence, when we think about this knack technique, is pre-contractions, functional training in daily activities, nocturia and habitual waking, lifestyle education, fluid intake, sleep hygiene, bladder diary, monitoring, behavior modifications, pelvic floor muscle weakness, progressive resistance training, biofeedback, functional integration with movements. It's very important in these cases. If we think about scar tissue rigidity and adhesion, scar mobilization, soft tissue massage, shock wave therapy, self-mobilization, education, abdominal weakness like diastasis recti, core strengthening, abdominal wall training, posture correction, breathing coordination, overweight, abdominal obesity, its weight management support, aerobic activity, lifestyle modification, reduce cardiovascular health, endurance training, walking or cycling programs, gradual load increase. And also back we go to sexual functions. Like I said, it's pelvic floor training for erectile dysfunction, vacuum erection devices, sexual rehabilitation programs with physicians. For loss of erection after surgery, penile blood flow stimulation, partner education, psychological support, persistent incontinence despite training, education about medical devices, about penile clamps, condom catheters, male slings, artificial urinary sphincters, psychological distress, its counseling support, relaxation techniques, stress reduction, stroke exercises. And if we think for my patient, outcome, the clinical case. After 6 months of physiotherapy, the patient's urinary incontinence remained minimal and irregular, especially after an intensive day. A slight leakage may occur during physical exertions. The patient does not use pads in daily life. Overall, the result is assessed as good. The patient says it's good. Sexual function, erection has not been restored. However, together with his partner, the patient has found alternative ways to compensate for this function. And the scar no longer cues concerns. It has become more elastic, and there is no discomfort or stretching sensation during movements. The another abdominal wall musculature has strengthened and improved. Body weight has not decreased. And this was my literature. And also I want to thank you everyone to being with me today. This is a small greeting from Latvia, autumn. These trees are starting to paint themselves in beautiful colors. I hope you also have a wonderful day. And if you have any questions, please feel free to reach out to me and I will be happy to answer them. Thank you.
Okay, great. Marta, thank you very much for your presentation. It's really highlighted the vital role of physiotherapy that plays in pelvic floor, supporting patients undergoing radical prostatectomy. So thank you very much. I think it was very well presented. And now we will provide time for the participants to ask some questions. So if anybody, I had a few minutes problems with the internet, but I was able to get back, so I apologize for that. But I see that everybody is still here comfortably. I hope the recording part wasn't affected. Anyways, does anybody have a question for Marta? Please go ahead. You can write the question on the chat box or just ask her the question. I thought that yeah, the case study was very good because I think it really brought a very, a well example straight from the clinic, so everybody can really understand. And I don't know, I think, I'm not a pelvic floor therapist, but I think I work in oncology. I think asking those questions are very important to our patients, if they are experiencing any problems with their pelvic floor function. And I ask specifically, 2 questions that what you mentioned about sexual health and about sexual function, sorry. and about control of the bladder. So thank you. Here there are questions. What is the knack technique? If you can answer,
Like
please.
patient, no, they need to turn to go motion. It will be hard for here. They do contraction before this motion and do this thing, and then after they relax muscles and go back. It's like we want to move the hard thing, lift up. We contract before these muscles and do this motion. When motion is end, we relax our muscles. Like we feel we need to cough, we contract our muscles, cough, and then we relax. And also this, it also works to this systematically. And
Then there's a question by Eliane. Do you systematically prescribe vacuum penile pumps when erectile dysfunction is present?
I say many of patients say, oh, no, it's not actual for me. I'm old for this. But sometimes they come back and, oh, no, I think I need to this. And then I start to tell about these medications, because sometimes urologists don't say about these inhibitors, these medications that we need to pills. But then I say, you need to go to your urologist tell about your medication, because she also, the urologist don't know, maybe this patient's not actual this thing. But they can, if they start this question, if we start this conversation about sexual health lives, I tell about this, about mechanical, about automatical erection pumps, and this is, these patients buy or don't buy, it's buy by sell, but I say these things because it's work, it's good.
Okay, and then Emma mentioned that the CNAC is a preventative PF. Emma, if you can share, remind me what are the initials for PF contraction to splint the pelvic floor when a challenge such as a cough, pelvic floor, sorry. You see, I'm not a pelvic floor therapist. It doesn't click. Pelvic floor contraction to...
Yes, it's like I say, it's like a motion. We do the contraction of pelvic floor muscles. We do this motion, which can do this incontinent thing, leakage. And when we do this motion and we relax this thing. There also was a question about sexual life. It's also, we need to educate patients, because many patients don't think that they don't have erections, they don't have orgasm. But we know that it's not necessary to get erection to get this orgasm. And it's also educational things. We talk with patients about this, because there's many ways. I think sometimes the patients come to us and I hear these stories, how they make this problem, how they solve these problems, because they use massage oils, they have used this vacuum erection device before sexual activity, and this is the reason, but something special like interventions. It's training, pelvic floor muscle training, it's vacuum erection device, it's medication from urologists for this, and also this is education about this process. And if it's necessary, I work in multidisciplinary team. I help who can help for these patients.
Okay, very good. So you answered Matt's question about specific interventions do you use to improve sexual function outside?
Yes, right.
Okay, very good. Thank you. And yeah, you can read what Jackie mentioned, that she thanking you. And I agree, the work is very impressive. It is gratifying that your work has advanced treatment to a point where we can be accepted to work with patients before surgery. That's much appreciated. And I agree, pre-rehabilitation is important, definitely in this treatment. Okay, very good. Anybody else has a question for Marta? Okay. So again, I think this was very important and very helpful. So we really appreciate your presentation, Marta. Thank you very much for providing it today. And yes, I wish a good rest of the day for everybody, or evening or morning, or yes. So thank you. Thank you.
Thank you very much, Marta. And